Hello, NT Level 6. Good morning. How are you? As I promised you that I'm going to give you a session on mood disorder, a combination of mood disorders together in a summary. It means that I'm going to discuss for brief, and when you read through the notes which I sent to you, you will find some of the things which I covered. So this is called summary. And you have to remember, make sure that you read properly those notes, you compare with this audio, then you will get something. Mood disorder, facilitator Nicodemus. We have 5 learning objectives. I'll pass through. Define the term mood disorder. List disorders which fall under mood disorder. List common causes of mood disorder. Explain common symptoms found under mood disorder. And describe treatment and nursing care of mood disorders. When talking about mood disorder, these are disturbances in emotions that cause discomfort or hinder daily functioning. The disturbances on how people respond to emotional feelings. When you talk about a mood, it refers to feelings or emotions. Mood is any sustained emotion with a major influence on person's perception. As the person feels, that is the way he's going to perceive. So this emotion state for the patient determines the general attitude of an individual. The person feels, the person perceives. After feeling and the perception, then the attitude will be projected to the individual. Then individual will be seen. And at that time, you are going to categorize that this person has such type of mood. Of course, there are 6 mood disorders. Among of them is mania, hypomania, manic depressive psychosis, sometimes called bipolar disorder, depression, involutional melancholia, and the dissociative and the somatoform disorders. The dissociative and the somatoform disorders, if we remember, we have covered because it was being learned during NT Level 5, Semester 1, when we are talking about the basics of mental health. So you have to remember and review. Depression, as far, is more common disorder, and it is characterized by sadness, feeling worthlessness, and the social withdrawal. The person becomes very sad. The person feels very sad. The way he's talking, walking, feeling, eating, thinking is retarded. That's why it is called also is an abnormal extension or over elaboration of sadness and grief. Depression can be associated with grief and bereavement. So the term depression can refer to a sign or symptom or syndrome, emotional state, reaction, disease, or clinical entity. So the clinical condition that is severe, maladaptive, incapacitating, and the depression may range from mild, moderate, severe, without a psychotic state. Psychotic depression is common, account for less than 10% of all depression. If you check all depression, mostly it takes almost 10%. Major depression can begin at any age, usually begins in the mid-20s and the 30s. Approximately 1 out of 8 adults may experience major depression in their lifetime, especially from 45 years onwards. People may experience depression. Common behavior found in a depressive patient. 1. Feeling and attitude. These are called affective. Most they present with anxiety, anger, apathy, bitterness, rejection. They have denial feelings, guilt, helplessness, hopelessness, loneliness, low self-esteem, sadness, and a person worthlessness. Mostly, those are the things which a person with depression feels, and that is the attitude, even if it's not there, but the person presents with such features. But physiologically, responses to depression, mostly they feel anorexia, they feel abdominal pain, they complain backache, chest pain, constipation, dizziness, fatigue, headache. Some of them, they have impotence in male, frigidity in female, indigestion, insomnia, lassitude, menstrual changes in female. They feel nausea, always sleeplessness, disturbances, and if you call, they are non-responsive. If you check these people, they have weight change, mostly decreased body weight. On cognitive feature, person is ambivalence, confusion, inability to concentrate, indecisiveness, not able to make a decision quickly, loss of interest and motivation, pessimisms. They blame themselves, self-blame, depression, self-destructive thoughts. I want to die. Much better I die. I should not continue living. Patient becomes very agitated when you check the person, the way of walking, the way of talking, the way of eating. It reflects the way of thinking, which is retarded. The second condition is mania. Mania is a major mental illness, which is characterized by mood disorder, especially hyperactivity, understanding, behavior, and violent. Very violent. Mania is a functional mental disorder with a distinct period of psychophysiological activation. A manic person, mostly, if you check, is very clean, is very euphoric, or very happiest, very excited, very socially. That is a manic person. Because a manic person may bath even 4 to 5 times per day because he wants to be very clean, very hyperactive. And hypomania is a mild form of mania, which is characterized by talkativeness, restlessness, and sleeplessness. The following are symptoms of mania. As I said, the mood is elevated, very irritable, very euphoric. Is very hyperactive, taking of too many activities at once. At once has a lot of things to do. And he thinks that is very perfect, while he's not, but has a lack of judgment in anticipating consequences which will occur in relation to the activities which he's doing. Always has a pleasurable speech and a rapid, accelerated speech, irrelevant speech, incoherent speech are more common to manic person. Has flight of ideas. The thought is more quickly than they can be expressed, jumping from one idea to another. That's why if you combine flight of ideas, that's why he's having a lot of activities to do at the same time. Very distractible and violent, can harm anything, but is thinking that is more important than others. This is called inflated self-esteem. Then a manic person has increased libido. The increase of libido is because of the increased noradrenaline secretions. Grandiose delusions, mostly they think that they are more important, as I said. They think that they can do anything which they they can, and they think that they are more higher class than others. Mood may be irritable, especially when plans are inflated. When he wants to do something, then you obstruct it, then the person becomes irritable. After becoming irritable, that's why he becomes also violent. Loss of weight because has no time to eat. Always thinking to do something because of flight of ideas, and has insomnia. The speech is so loudly, may start talking slowly, then it becomes intonation detergation. Mostly all these are irrelevant speech. Labile mood, shifting mood from depression to euphoric, and he may laugh and cry without any kind of provocation. The third disorder which I'm going to talk is bipolar. Bipolar is a psychotic mental disorder characterized by mood disturbance with episode of either mania or depression. Mania means elation, depression means mixed episodes. Depressed is a psychotic disorder characterized by swinging mood of depression and elation. The most common picture of bipolar, if we want to diagnose it is based on ICD-10 with the following criteria. 1. 2 or more episodes of mood disturbance, one must be mania. 2. Manic episode must last at least for 1 week, and a depressive episode lasts at least for 2 weeks. If you check, the person is very happiest, euphoric, wants to do a lot of activities doing, is more exaggerated things. This is a manic episode. Mostly it lasts for 1 week. Then the person shifts to depression. Under depression, the person may stay in depressive phase almost 2 weeks. The abrupt or remission may occur. Cause and the prognosis: mania has abrupt onset and they may last for about 6 months. If is untreated, you may see person is working, walking, doing other things. After 6 months, then there is a remission or the person may recover. Depression tends to last longer and they end less abruptly than manic episodes. Mostly, depression, if takes a long time, may end up into suicide. With the treatment, the frequency and the severity of episodes is greatly reduced and they live productive lives. If you recognize a manic phases or a bipolar phases, you give treatment. With the treatment compliance, then the person is going to live productive. So mortality and the morbidity rate of bipolar disorder is higher. Mostly is suicide or accidental death. But concurrent illness may contribute to high mortality rate, especially if there is a repetition of manic phases or depressive phases. Then the person may die later on. Then you start looking for cause of death without recognizing. When you talk about clinical features of bipolar phase, you have to remember there is manic phase and a depressive phase. On manic phase, if you remember well when I was giving you introduction on mania, on manic phase, the person is elevated, has elevated mood, has grandiose delusions. Most of these, they say that they are Jesus, they are angels, that's why the door is open. And the others, they have a great power, increased energy and activities. They have always flight of ideas. On increased energy and activities, they may work for long hours without resting. Rapid pressurable speech when you are talking does not give you chance you to talk, wants to talk himself. They have increased the libido because of increased neurotransmitters in their body. That's why they may lead into inappropriate sexual activity. Example, promiscuity, removing clothes in the public, and mostly you may find at Sangha institution. Impaired judgment and passive behavior leading to gross overspending and poor decision making. They may buy things which are necessary, which does not correspond with the amount of money spent. They decrease need of sleep, mostly they are awake, increase the sociability. If a manic person goes to the group of people, he may create a sociability with a lot of people at once, at the same time for a short time. But they have impaired concentration, have hallucinations, terrifying in nature, and a voracious appetite. On sociability, the friendship does not last longer because of the decreased impaired judgment and the concentration. On a depressive phase, they have depressed mood. Remember, in a manic phase, elevated mood. But also they have feeling of guilt and worthlessness. They think that they are not useful to the community. Reduced self-esteem and self-confidence, reduced energy leading to fatigue and diminished activity, ideas of suicide always because of the depression and because they are thinking that they are useless. Their decreased libido may lead to erectile dysfunction and impotence. Decreased motor activity, disturbed sleeping, loss of interest, reduced concentration. Also, they have hallucination, terrifying nature, and they have disturbed appetite. The third is involuntary melancholia, which is a depressive mental disorder appearing during the involuntary period, 40 to 55 years for women and 50 to 60 for men, in people who have no history of previous mental illness. If the person is having previous mental illness, especially obsession, obsessive compulsive or depression during later life, can't be diagnosed is having involuntary melancholia. So this person has no any history of mental illness previously. Remember, involuntary means rusting to change of retrogression which occurs later life. Incidence, the condition is more common in women than in men on the age of between 45 to 65 years. Men's are less affected than women's. Mostly, a person with involuntary melancholia may exhibit the following characteristics. Previously had ambitions, they are perfectionists, they had a high standard and anxiety concern with their health, they are hardworking, religious and God-fearing, lived in a smooth life, had a good financial status, careful obsessions, rigid and emotional responsiveness, had very keen in all aspects during work life and other things. So these are the things which the person was doing or anticipating to do. Later on, they are likely to develop involuntary melancholia because at that time it has lasted change to the growth and the development and has no ability to work more as the plan has already failed. Common features on involuntary melancholia, mostly they have delusions of sin, delusions of poverty. An obsession with death, always thinks much better to die rather than living. They have delusional fixation on the gastrointestinal tract, like I can't eat because my intestines are obstructed. They become easily angered, sleeplessness, as insomnia, has unprovoked spells of weeping, even when you are talking a good news to him or to her, then the person during response will start crying. Complaining and pressure on head. Mostly you will see that they are complaining tension, headache. They tend to worry excessively about minor matters. Even a minor thing, when you are talking with him, the person is going to worry excessively. Wringing of the hands and a sense of hopelessness, especially when you are talking. Suicidal impulsion or suicidal ideations are common. Hypochondriacal and nihilistic delusions are more common to these people. Hallucinations and delusions may occur, but frequently they are often tactile, especially genital in the woman. They may complain that something is hurting into the genital area. But auditory and visual hallucinations also are more common, even though they are rare. Anxiety, tension, restlessness are more common to involutional melancholia. Mostly involutional melancholia may be precipitated by the following factors: loneliness, unfulfilled ambitions, physical illness, unwanted, no longer attractive life setting, but also becoming useless in the society. These are more commonly precipitating factors. Remember, later life, they become loneliness. They feel that they have not fulfilled their ambitions. They suffer from physical illness for a long time, chronic one, and they think that now they are useless to the community or society, and they are no longer attractive to the life settings. But over concern, financial bereavement, loss of beloved one, perhaps children, perhaps husband, perhaps wife, enforced retirement. Please retire because the time now you have to go and rest. Loss of children to marriage, loss of power and positions. Common etiological factors for mood disorder. All mood disorders, they follow under the following etiological factors. 1. Genetic vulnerability, psychosocial stress, stressful life events that overwhelm coping mechanisms, personality disorder, hereditary, and the personality style. Just remember, and if you refer to the causes or etiological factors of mental illness, they fall under genetic vulnerability, psychosocial, personality, hereditary, and personality style. These are common etiological factors for moody disorder. Addition, dysfunctional relationship, social stress, physiological stress like hormonal and biochemical changes, fatigue, physical complications, electrolyte disturbances, and environmental factor. Drugs used for moody disorders, tricyclics, antidepressants, and MAOI, especially for depression, is very useful. Amitriptyline, like as a tricyclic, phenothiazine drugs such as tranquilizers like haloperidol, tifloferazine, chlorpromazine, sterazine, and others. These are mood stabilizers. In bipolar disorder, a combination of mood elevator and a tranquilizer may benefit the patient depending on the phases of the patient's moody disorder. ECT in severe cases or for the patient who does not respond for medical treatment can be very useful. Cognitive, psychosocial, and psychotherapy can be used to such patient when the person starts recovering. Family and community involvement is very important because the person is going to go back to the family members and to the community. So these can be taught the precipitating factor and how to handle the person and the drug compliance. Pay attention to physiological needs of the patient, such as body hygiene, feeding, especially for patient with mania, has no time to eat, because of increased activities, and the depressed patient refuses to take food because he feels it's not wanted to the world. If it is mania, the patient has no time to eat. Involuntary melancholia wants to die. That's why does not like to eat. And the most complication is the suicide. Mood disorder has major complications, and the major complication is the suicide. Let us see in summary on what we have talked or I have discussed above. 1. Mania. Mania has a daydreaming or racing thoughts because thinking a lot of things. Mania has difficulty in sleeping because has no time to rest, has no time to do anything. Feeling of over-exaggerations. That's why if you check the picture, it shows how is feeling the person, always exaggeration, but has energetic, always doing things. That's why I said that also can work for a long time. Inflating self-esteem. The person also may think that is more important than others. Symptoms of depression. If you check, this is a depressive area, has a loss of self-confidence or self-esteem, has inexplicable feelings of guilt, almost has constant sadness, recurrent thoughts of death and suicide, trouble sleeping, change in psychomotor activities, the way of talking, thinking, behaving is slowed. Loss of energy, increasing fatigability, and a decreased ability to think or concentrate, change in appetite, then loss of interest. In the bipolar, as I said, that there are 2 phases. There is manic and depressive. This is manic phase. In manic phase, onset between 18 to 30 years old, the mood elevated, expensive and irritable. The speech, as I said, loud, rapid, panning, poor judgment, clanging and vulgar. Weight is lost because the person has no time to rest, has a grandiose delusion, vote for me, next president, that is delusion, thinks that he is going to manage, distracted when things are obstructed, hyperactive, need for sleep is decreased because of the activities, a lot of activities at once, inappropriate dress, just look how he's dressing, a lot of decoration with him, flight of ideas, skipping from one idea to another. That's why always you will see that he's having a lot of activities. On depressive phase, mostly you see that has a previous manic episodes. That's why he's going to another phase, feeling of worthlessness and guilty, hopelessness. Increased anger, irritability, interest is decreased, even a pleasurable pleasure, the person is aloof, negativism, views, fatigue and energy is decreased, decreased appetite, develops constipation, insomnia, decreased libido, suicidal preoccupation or ideation is higher, and they may be agitated or have movement retarded. Then other syndrome of depression and mania, mostly it is involuntary melancholia, has a severe depression, has marked agitation with the presence of psychotic features and the somatic symptoms. Always I say that it complains about physical features. But mixed anxiety, depressive psychosis presents with anxiety symptoms which result in significant distress and instability, and important to consider diagnosis of either mood disorder or anxiety disorder. Now, thank you very much for listening.